Welcome back. I'm Krishna Ramachandran, one of the PTAC members. As you know, PTAC will issue a report to the Secretary of HHS that will describe our key findings from this public meeting on improving multi-payer alignment in value-based care. We now have time for the committee to reflect on what we've learned from our sessions today. We will hear from more experts actually tomorrow, but we want to take the time to gather our thoughts before adjourning for the day. Committee members, I'm going to ask you to refer to the potential topics for deliberation document during this discussion. To indicate you have a comment, please raise your hand in Zoom. Yeah, I'd love to start with some volunteers here. Lauren,
I'll
thanks
get
for
us
being the
started.
first one. Yeah, thank you.
So I'm really struck today by the universal lesson. So one quote that sticks out to me is what we're really trying to do is move communities, integrated systems from a transactional relationship to a partnership model. And that involves deep trust building amongst partners and providers to have shared values, a payment model that works, or a way of doing that and metrics that work. But also a really important role that continues to come up is that convener role, the investment and the practice change, the capacity building, and also some of the work around systems change and redesign of systems of delivery. That the funding of that kind of role is really critical. We saw that in One Care Vermont. We heard that from the last sessions. I think really thinking about how do we continue to invest in those integrated roles. I've seen on the ground in practice what happens when we do early investment and then take that infrastructure away, how difficult it makes it for the change to continue. So very important for success in multi-payer alignment and roles. And then also thinking about shared infrastructure, what a difference that makes. So the difference in multi-payer alignment in states that had one HIE and support for the data analytics, advanced payment to really equalize the table with who's at risk, and also thinking about integrated care coordination structures and how that can be disseminated, especially for rural outreach, and to equalize the table with access to specialty.
Yeah, well said, Lauren. Yeah, I think the convener, the infrastructure, I think key elements that we heard as well that are sort of through line across many sessions too. Lee?
It was well said, Lauren. I 100% agree with everything that you said. I was struck by really with these experts who have all been there and done that in the real world emphasized is this isn't really about a metric, a program, an incentive. This is operating at a level way larger than that. This is culture change in a community with community leaders, employers, government agencies at multiple levels, and providers at multiple levels. And so I think that just really struck me that it's clearly not, you can't issue a program and think it's going to be successful, right? You've really got to take it and do the hard work of culture change management throughout a community, which is when it's as large as a state, is a multi-year process. So that was very striking. Again, as I'd commented earlier in the first session, especially was really struck by the unanimity of the opinion that Medicare Advantage has to be part of the portfolio, because only when it's included do you get to the 60 or 70% of a patient population that's required to get engagement, get health systems and providers willing to change what they do. So I think that was really striking. I guess this last session, just kind of talking about what were the elements that were necessary to get providers to change. And they spoke, looking for my notes, but they spoke to reliable revenue, multi-year projected reliable revenue. They spoke about simplification and making it easy to understand by the practicing doc and the patients both. If you have to have an actuary to explain it, it's not simple enough, right? So the programs have to essentially insulate both providers and patients from that level of complexity. decrease the burden of program administration, and emphasize the criticality of just predictability, which speaks to, a 1-year plan with changing metrics and or benchmarks every year is just probably not going to move the needle. It takes a longer time horizon to affect culture change in a practice environment. So those were all things I took away.
Great additions.
I can go
yeah,
next.
go ahead, yeah.
I'm gonna just pile on to what Lee just said. We heard simplification all through the sessions today from multiple speakers, even one saying we should abolish MIPS and revamp the STAR program. And I couldn't agree more, because from my provider days, I mean, when you've got multiple ACOs you're participating in, multiple health plans you're trying to hit measures with, it's crazy. So that came out loud and clear. The second point, and on that simplification, I love the line, whenever you need an actuary to calculate something, you have a barrier. So simplification was one of them. The second line was push from above. We heard that multiple times. And one person even said, if we don't have CMS at the table, it's difficult. So again, that power from the top, pushing down on this thing to make sure everybody's participating and we're all going towards the same end. The line, believe in it, understand the nuances, and fully fund it. Somebody's got to have that kind of influence over it. And the final thing I was intrigued about was in that Pennsylvania program, giving the hospitals funding their budget. Now, I didn't ask whether they got extra payments for, high risk, high intensity services. I'm sure there was a reconciliation that brought all that into the end. They did mention reconciliation, but what was the line? You need predictable revenue to build infrastructure. And so that applies to the physician side just as well as it provides to the hospital side, though. I think, there's infrastructure necessary for the change we're talking about. You need predictable revenue. So, in the multi-payer environment here, those three pillars: simplify the system, have push from above from the biggest entity, meaning the Medicare and Medicaid, and then revamping the structure to prospective payments. I thought it was a good day.
Yeah, well said, Larry. Other thoughts, comments?
I can go next. So I really like the way Mike outlined the 5 key components that need to be simplified. It's around attribution, quality, risk adjustment. I can't remember the other 2, but those 5 key pillars I thought was a good summary of how we need to think about simplification. Fewer programs was another one. And the attribution piece came up again when Karthik spoke, is even if we want to allow Medicare Advantage participants or payers to have creativity around how they create their programs, there are certain components of the program that can be made standardized without necessarily impacting their ability to be creative or innovate, like attribution, for example. And I remember Karthik saying that one of their payers does attribution really well, others don't, and that has a huge impact on how they're able to manage their population. So if Nicholas was able to take a couple of those key things away, is that we don't want to stymie innovation and creativity, but at the same time, having certain standardization will allow for better population-based management, I think was a good takeaway.
Great additions. Other thoughts from folks? So.
Yeah, I can jump in. I agree with a lot of what's been said. I think one of the grounding things, and I'm glad this was our first session today, was really about kind of like being kind of entering with humility and being humble about what we're trying to achieve and what we can achieve here. I think it's a little bit more than that. I think as I've listened today and heard responses from our subject matter experts, it strikes me that, when we're talking about alignment, there's kind of this pull towards like standardization, what we've called in the PCDT kind of more exact alignment, and then flexibility, which might be you think of as like directional. As long as you're working on quality in a chronic disease way, we don't have to line up around the details and the specifications. And I don't think they are opposing principles, but I think they're kind of complementary design levers, what I would call them. And I think standardization promotes comparability. It helps with oversight. I think flexibility allows innovation, responsiveness to local needs, which is what you want. I think MA provides a really important example of that. I think, Larry mentioned things around mandatory versus voluntary. I think all these things that we talk about lives on the spectrum of, do we want to standardize or promote flexibility? I think I mentioned this a little earlier, but I continue to grapple with what is the policymaker's role in that then? And I think perhaps the best word I can think of, at least today, is calibration, right? So changing flexibility affects certain things and vice versa. There's always a trade-off there. So I think simplification is good, but it has its limits, right? With greater standardization, reduces administrative noise, it makes things simpler. This is good, but it also limits choice. It limits the ability to be flexible to local needs, to kind of map the culture that Lauren and others are talking about. I think we just need to be humble and acknowledge that there's a trade-off there and not pretend it doesn't exist. And I think our speakers helped us kind of realize that today in a kind of real world way. I guess the last thing I'd want to say here is just that, I think we can simplify things. I agree with Henish. I think I agree with Henish. I think we can simplify and align attribution, risk adjustment, quality measurement, et cetera. But I would humbly push back on this idea that like these models that we're talking about are inherently hard, right? We just like need to acknowledge that like fee for service works because time and materials, parts and labor, and you can kind of map that out as a clinician or as a group. When you're like risk adjusted for what the spending should be for these populations that may or may not be, it's hard. So you're going to need actuaries, you're going to need statistics, and that's just an inherent part of this. And so I don't want the simplification to overlook that point. Can we make it more rational and standard? You bet. I think it's a dial to calibrate against flexibility and local needs. And I think some of these things are just inherently complex, and that's the world we live in. So, but anyway, great day.
Yeah, well said,
Josh,
yeah.
Josh, on what you just said, it would really help if what CMS did was to set all those risk adjustment rules, because they're different. Whatever payer you're getting a risk adjustment from, they all have their nuances, and you always suspect that they've created their special nuance just to decrease what they have to pay you. So, some standardization there would really be welcomed by everybody.
Yeah, and I think Larry, I know of all people, this. It's like I think we all know this. To somebody, it's not like a yes or no, standardize or not, but it's like what you standardize and to what degree. And I thought we started with the easier task today. In the morning, we were talking about insurance vehicles for the elderly in America, MA versus fee for service, and different flavors of MA. We're wading into much harder case of like, children and women against seniors in America, against employed populations. As we do that, I just think this trade-off is going to be hard, right? Like acknowledging some complexity is structural, and that you can't undo the net cons without losing some of the pros, I think is the point here. So.
Yeah, well said. I think both of you. I mean, inherently, I think it's harder to simplify it in my mind. I mean, I think the way where we can align, I mean, these models are just complicated, as Josh just said. Like when you think about anything that does that global budget, it's like, well, like how does it compare to my fee for service? What's the comparison? What's the adjustment? How do I set the rate for that population? There's a ton of like complexity just built in, especially coming from a world where I've had to design some of these models. But I think can we align better? Can we streamline better? There's still some like good nuggets I think today we had. Other folks' thoughts? Happy to share mine, but I figure I'll give you all more room to share thoughts.
I'd be happy to jump in.
Yeah, thanks.
Yeah, I agree. It's been a great day. I think my big picture takeaway from today is what PTAC has been saying for a long time now, namely that multi-payer alignment is essential to scaling value-based care. But I think what today shed light on is that this alignment must be very pragmatic. So from today's morning session, it's clear that CMS's convening role and or regional conveners have the potential to accelerate collaboration, yet durable progress really requires standardization around timely data, clear attribution, ideally a concise core quality measure set, and equitable payer cost sharing so providers aren't forced to cross-subsidize transformation. I think it's also evident from today's session that a primary care focus seems to be the common linchpin. Strong PCP relationships and reliable attribution methodologies enable early engagement and lower utilization. From the morning session, I was struck by the extent that Medicare Advantage often outperforms Medicare ACO. I think primarily because of better attribution, timelier data, and an expanded toolbox, including, I think as Karthik mentioned, utilization management and narrow networks. The afternoon sessions demonstrated valuable state experience showing how to operationalize this. Multi-payer reform seems to succeed when a strong neutral convener and inclusive governance facilitates sustained engagement from payers and providers. Also, predictable prospective payment structures and aligned primary care funding seem to reduce provider burden and enable transformation, as well as shared metrics, interoperable data infrastructure, and upfront investments in practice transformation analytics are also essential to scale and sustain progress. Some of the unanswered questions for me include how to operationalize Medicare Advantage engagement at scale when managing MA plan heterogeneity that was mentioned this morning, which kind of specific core quality measures should be standardized across Medicare product lines without stifling innovation, what kind of legal waiver or market flexibilities are needed to enable sustained payer collaboration and long-term financing and convening. I look forward to hearing how our subject matter experts think about addressing these challenges and others more in tomorrow morning's session.
Excellent. Thank you, Walter. Lindsay, I think I thought I saw you go off mute. So
yep, it was a competition there for a minute. Yeah, I mean, I think some of the themes we heard today, while not necessarily specific to multi-payer alignment, warrant probably repeating, and maybe this is repetition again if I missed it, but from Michael Chernow's talking about, what do you need to succeed, and talking about, systems need stability, not for next year, but for 2030 and years into the future for systems to actually transform. And I think the quote that stood out to me from him was, do less, more simply for a longer time horizon. And it seems like we're starting to learn some of those lessons, but maybe it's not just a complex new model as refining existing ones with doing less. I think we heard a couple times just themes around HIE-enabled data sharing helped increase communication and reduced low-value care by understanding what's been done before in the broader healthcare ecosystem. And I think also themes of it as the HIE is a public good, and how might that further some of the multi-payer alignment if there were common data. And then I think, when explicitly kind of talking about what's the role of the state or the federal government for that matter in multi-payer alignment, it sounds like from the Vermont learnings, at least a little more push would have been helpful. And it's not just performance, but it's actually meaningful help along the way, and not just quality metrics or whatever it may be. And then similarly, that requirement that payers stay in. So maybe not dictating the exact terms, but there has to be participation and communication for success. Those stood out to me. Thanks, Krishna.
No, well said, well rounded there. Any other folks that haven't gone? I have some comments to add, but I think I'll. Okay, wonderful. I think the challenge of going last is that you've covered much of the, my own observations as well during the day, but yeah, but I thought in the spirit of rounding it out, interestingly, I think this whole, back to sort of the speed of trust comment I made and or asked one of the questions on it, comes back to that trust alignment. I think was still such a key piece of this as well. And so that was, I thought it was another sort of through line that stood there. And I think there was a comment made on just like stakeholder motivations. There's just obviously, bringing people together, but also making sure that the various parties, payers, providers, other stakeholders are actually aligned, and we have the motivation to actually align. I thought was key there. Similar to Lauren's observation, the role of a convener I thought was helpful and needed, whether it's regional or broader. Particularly the contracting example, because that's the true reality, right? When these things happen, the multi-payer to multi-provider, it's a sort of a mess of a contracting, and certainly the convener has the opportunity to sort of align the contracting, maybe less about reducing complexity as much as just like same but different variability. There, I think the interesting opportunity there from a contracting data, the core data set, some of you have mentioned as well. I thought that was helpful. And then the shared infrastructure, Lindsay, you and others mentioned that as well, from a data reporting. How can technology be consistent technology be an enabler, whether it's an HIE or some other methodology there. Certainly the advancing payments stood out. It's one of those challenges we've had with just fee-for-service value-based care, particularly ACOs. It's so delayed and time delayed. And so where we can front load, I think is good and certainly will help with the engagement and alignment. Particularly, it was good to see the global budget work in Pennsylvania as well on this space there. I also appreciated some of the speakers' comments on just planning as a strategic sort of function there as well. How do we make sure we can create the artifacts that we can reuse to scale? I thought was just a sort of a underemphasized, but I thought it was helpful. Be like, it's good governance and good organization can be helpful. And then the sort of push from state policymakers, that nudge, I think was key, as well as just continued stability from our payers and policy folks as well, whether it's funding or measures, other things as well. So yeah, those are things that stood out for me, and I think many sprinkled in with many of your comments as well. So I appreciate you all. David, I don't know if you were able to get off mute. If there anything else you wanted to add as well, so. I can't hear you if you're saying anything. We still don't hear you, David. But maybe just if you want to send out your thoughts via email too, that would be good. We can incorporate it. Yeah, if there's no other thoughts, team. Yeah, thank you all for obviously your contributions and your sharing your insights and observations during the day as well. I love this session a lot, just because I feel like you all just look at the world so differently and bring such unique and perspectives from your worldview. So it is just always awesome to see how you all see the day and how you bring it together. So one of my favorite parts of these meetings. So thank you all. Maybe I'll give it to Lee for just logistics about tomorrow or other things as well.
Very good. Thank you so much, Krishna. This time, I want to thank everyone who participated today, our wonderful session experts, my PTAC colleagues, all the amazing staff that make this possible, and those listening in. We will be back tomorrow for our next session at 9 a.m. Eastern Time. We'll be joined by 4 more incredible experts who will share their perspectives on addressing challenges to advance multi-payer alignment. There will also be an opportunity for public comment tomorrow morning at approximately 10:50, that's 50 a.m., before the meeting concludes with the committee discussion. We hope you will join us then. We look forward to continuing the conversation tomorrow, and thank you for today. The meeting is adjourned. Be well.
Produced by the U.S. Department of Health and Human Services.